Good evening. My name is Suhail Rauf, and I'm Chief of Pulmonary Critical Care Medicine and Sleep Medicine at Lenox Hill Hospital in Manhattan. It is truly a privilege and a pleasure for me to introduce our speaker for the evening, Dr. Nicholas S. Hill. Nick is Professor of Medicine at Tufts University School of Medicine in Boston, and he is the Chief of Pulmonary Critical Care and Sleep Medicine at Tufts. Nick has several areas of expertise to his credit. He has published on pulmonary rehab, pulmonary hypertension, and several other fields. He is recognized as an international authority on non-invasive positive pressure ventilation. He has written several guidelines, including co-chairing the European Respiratory Society and the ATS guidelines on non-invasive ventilation in 2017. He is also actively involved in the pursuit of understanding the physiology and indications of high-flow oxygen. He was the president of the American Thoracic Society in 2011 and 2012. I have had the distinctive pleasure of being associated with Nick for many, many years, and I've always been inspired by his enthusiasm and his ability to take on a topic and synthesize all the information and be able to present it in a manner that is easily understood. The reason we are having this this presentation today is that in the midst of the COVID-19 epidemic, we are finding that people are getting intubated, and if you look at the statistics is fairly dismal. Only about 50 to as many as 50 to 90% of the people who get intubated do not get off the respirator and have a mortality that is really has not been described in most other diseases. So the question that confronts us is, can we utilize high flow oxygen to prevent or even delay intubation? Can high flow oxygen or non-invasive ventilation be utilized to extubate patients earlier and to keep them off mechanical ventilation? On the other hand, with so little known about COVID-19, is this practice likely to result in an increased risk of transmission of infection to healthcare providers? So we felt that it was a very timely discussion of all of these points, and I would like to request Dr. Hill to talk about non-invasive as well as high flow oxygen in the setting of the COVID epidemic. Thanks for joining us, Nick.
Well, thank you, Suhail, and it is an honor for me to be introduced by someone with your eminence, and you have framed the question very well. It is a very controversial topic right now and has certainly generated a lot of verbal sparring, if not fisticuffs. I did want to start by showing my disclosures. I do research and do some advising of manufacturers of some of the devices we'll be talking about. And what I'm planning to cover today is to talk a little bit more about the controversy and some of the guidelines that are out there. Start with some technical considerations and the physiologic effects of the modalities, high flow and non-invasive ventilation, and then compare and contrast how their pressure curves look. Talk about some of the evidence for clinical applications, and then wind up with some of the practical considerations when applying these devices in a clinical setting. So the guidelines, one could say simply are all over the map on what different groups recommend as far as the use of these devices are concerned. So on the top, the Surviving Sepsis campaign, sponsored by the Society of Critical Care Medicine, came out with a guideline just under 2 weeks ago, and they suggest the use of both high-flow nasal cannula and non-invasive ventilation. The asterisk there is that they do suggest that high-flow or non-invasive ventilation be reserved for situations where high flow is unavailable. And one remarkable thing about their guideline is that they don't even include high flow on their list of aerosol generating procedures. And as Sahel had mentioned, the generation of aerosol has been a big concern by caregivers with the concern that exposure might lead to higher rates of infection of healthcare providers. And we'll get into that more, but virtually every other guideline considers high flow and aerosol exposure risk listed as an aerosol generating procedure. The WHO, just within the past month, also came out with guidelines, and they recommended that high flow and non-invasive ventilation be used only under selected circumstances, not to be used routinely. The Australia-New Zealand guideline, also quite recent, came out with a fairly strong recommendation for use of high flow, but recommend that non-invasive ventilation not be used routinely. New York, where there has been a lot of controversy about this and where some centers don't use it at all and others do use it, at New York Presbyterian, as an example, they were cautious about high flow, but said it could be used in selected circumstances, and they recommended against the use of non-invasive ventilation fairly strongly. In Boston, the Mass General and the Brigham and Women's both have a guideline that says neither should be used routinely, and they favor early intubation and avoiding non-invasive as a general rule. And at Tufts, we recently came out with our guideline, and we consider high flow an option. We are using it, and non-invasive ventilation not routine. Now, with that as a backdrop, with regard to the variety of opinions on how these things should be used, let's consider some of the technical differences between the two. Now, one of the distinguishes characteristics of nasal high flow is that it is an oxygenated gas heated to close to body temperature and fully saturated, whereas with non-invasive ventilation, heat and humidification are quite variable. It's possible to use NIV without heat or humidification at all, but most of the time there is some, but it depends on breathing pattern and other factors. The thing that probably distinguishes these things the most, though, is that non-invasive ventilation, at least as we use it most of the time, is a pressure preset mode where you fluctuate between a higher inspiratory pressure and a lower expiratory pressure. And the difference between inspiratory and expiratory is your pressure support, which provides the assistance with breathing. Nasal high flow, on the other hand, is mainly a flow targeted mode. You set a certain flow and the device delivers that continuously, and the pressure thereby will vary. So with non-invasive ventilation, it's a pressure generator. With high flow, it's a flow generator. The circuits with which you provide the flow or pressure in non-invasive ventilation can be single or double. In your usual bi-level or BiPAP setting, it is a single one which has a fixed exhalation valve, which is to allow for exhausting of CO2, whereas with nasal high flow, It's a single circuit that's heated to avoid condensation with the fully saturated gas, and it can use either a hot wire heating system or a water jacket. With non-invasive ventilation, you can use a dual circuit critical care ventilator, and we'll get back to the importance of that in the COVID pandemic in a moment. With oxygenation, if you use more of a home-based type of non-invasive ventilation setup, the oxygen can be bled in, but there's a limit to the FiO2 you can deliver, usually to 50% or no more than 60%. But the critical care ones are designed to work with a blender that can vary oxygen between almost room air to 100%, and nasal high flow works the same. So one of the distinguishing characteristics is the heat and humidification, as I was saying, and this is very important for the tolerance of high flow. The currently available devices can go up to 60 liters a minute, depending on the manufacturer, and a dry gas going into your nose at that rate would rapidly become uncomfortable as you desiccate and get a sensation of burning in your nose. And by heat and humidification to body conditions, you greatly enhance the tolerance. Also, the interface is relatively loose fitting, compact. It doesn't get in the way of vision, unlikely to cause claustrophobic reactions. And the great comfort and tolerance that you get because of that is a large advantage of high flow, especially over non-invasive ventilation. It also permits unimpeded speaking and eating, which is another great feature for patients. If you have a full face mask or a helmet, it's not so easy. On the lower right here is Butterball the cat, who's using a standard nasal mask and is not too happy. Now, there are other physiologic effects that are very important for the function of high flow. One is that it accomplishes hydration of secretions and preserves mucociliary function. So it makes it easier to clear secretions, avoids inspissation and secretion buildup, and there are some studies suggesting that you can reduce the occurrence of pneumonia, including nosocomial pneumonias, with high flow. It's also an effective oxygenator, and it does so by two basic mechanisms. One is if it's at the higher flow rates, it keeps up better with inspiratory flow rate than standard oxygen devices like the NRB, which goes up to about 15 liters a minute of oxygen, non-rebreather mask. And so if you are someone with hypoxemic respiratory failure and you're breathing at a high rate and relatively high tidal volumes, your inspiratory flow rate may be at 60 liters or more. And the high flow is able to keep up with that rate without having to entrain a lot of room air. Whereas if you're at 15 liters a minute, a lot of what is delivered to your lungs is mixed with entrained room air, and the FiO2 thereby is well below the 100% that goes into the NRB mask. It depends on breathing pattern as to how much below, but it may be as low as 60%, 70% a lot of the time. It also flushes out the nasopharynx and eliminates the dead space, so that when you initiate your next breath, what you breathe in is largely the fresh gas from the high flow system with whatever FiO2 is set, rather than the just exhaled gas that has a much lower FiO2. So that also helps you maintain a better FiO2. Because it flushes out the dead space, it improves ventilatory efficiency, and it also pretty consistently decreases respiratory rate, which means work of breathing per minute is reduced and fatigue is less apt to occur. It has a slight amount of positive expiratory pressure, and it has been shown to increase end expiratory lung volume, which can also improve oxygenation. Now, this is supposed to be a video, but it's not hooked up right now, but we will use our imaginations here. What we're supposed to be seeing is 15 liters a minute, 30 liters a minute, and 45 liters a minute. And these are upper airways in a plastic model of a human upper airway, and the red is radioactive aerosol to show the flushing out. And at 15 liters a minute, there's some flushing that occurs, but at 30 and 45, it occurs much more rapidly. And so the point is that the effect on flushing out of dead space is dependent on the flow rate, and you achieve considerably more at 45 liters a minute than you do at 15 liters a minute. This illustrates the effect on respiratory rate. This was from a study that looked at 30 minutes of face mask and 30 minutes of high flow in the same subject with the order randomized. But on the left, we can see what the respiratory rate was on the face mask, 30-minute period on average. Looks like it's about 30. And on the right, the high flow for 30 minutes. And it looks like, to me, it's probably around 25. So most patients are getting about a 5 breath per minute reduction in respiratory rate. There are always some outliers, of course, and there is a straight line here. These are humans we're dealing with. But this reduces work of breathing by virtue of the reduced respiratory rate per minute. Now, the expiratory pressure is often posited to be one of the reasons that high flow is capable of reducing work of breathing, but it's not a large effect. This is the blue here are the fluctuations in nasopharyngeal pressure in a patient on high flow at 60 liters a minute. And at the peak, at the beginning of expiration, actually, we're averaging probably about 6 centimeters of water, or about 1 centimeter of water per 10 liters per minute flow. But during inspiration, we dip down. In a patient on standard oxygen, such as a non-rebreather mask, we're fluctuating around 0. So during expiration, we go up a little bit, inspiration, we go down a little bit, but there's no sustained expiratory pressure. Now, this is to show the contrast between non-invasive and high flow with regard to pressure swings. This was done by one of my sisters who's a medical illustrator. And what you can see here is that at the beginning of expiration, and this is actually drawn from the figure I just showed you on a longer time scale. But at the beginning of expiration, you get the peak as the patient exhales and achieves the highest expiratory flow rates. And then as the patient's expiratory flow rate tapers off, so does the pressure. And during inspiration, the pressure dips. And the dip could go below 0 if the patient were to inhale hard enough. And then during expiration, it does the same thing. During breathing on high flow, where the pressures are set, during expiration, in this case, 6 centimeters of water, the expiratory pressures actually overlap. But during inspiration, as it should, the nasal non-invasive ventilation goes to the preset 12 centimeters of water in this example. And you can see that there is a large disparity between the pressures of the two modes. Now, this is likely to make a difference in conditions where the pressure is important, such as patients with a severe COPD exacerbation or cardiogenic pulmonary edema. And of course, these are the things that non-invasive ventilation works best for. The evidence that we have to support the use of non-invasive ventilation is level A for acute hypercapnic respiratory failure in COPD patients and for cardiogenic pulmonary edema. But non-invasive ventilation has never been shown to be consistently effective for acute hypoxemic respiratory failure, such as we see with ARDS and such as we're seeing in the COVID epidemic. And in fact, the ERS ATS guideline on non-invasive ventilation that, as Sahel mentioned, I co-chaired, we made no recommendation. Now, we didn't recommend against non-invasive ventilation, as some people mistakenly think sometimes. We just made no recommendation. We said that the evidence isn't strong enough to recommend for or against. And we did say that there might be some situations where you consider a trial of it if it's single organ system disease, if the patient is otherwise stable and is being watched very carefully. But NIV has been challenging in people with ARDS and severe hypoxemic respiratory failure. And I think it's related to the fact that there is a severe oxygenation defect and you need a higher expiratory pressure than would be the case in someone with COPD. Because the pressures are higher, you get more leak. You get a desaturation very rapidly if the device falls off. These patients have high minute volumes. They're tachypnic. It's difficult for ventilators to meet these demands and synchronize, and dysynchrony adds to difficulty in toleration. The lungs often are stiffer, although it is important to point out that in COVID, at least some of the patients are not having very low compliances, as is typical in other forms of ARDS. But those high inspiratory pressures can also contribute to leak and less comfort. And they tend to be very sick patients. They often manifest sepsis, they get secretions, multi-organ system damage. They may deteriorate rapidly. These are all true of COVID patients as well. And in that situation, non-invasive ventilation would not be desirable, and these patients generally should be intubated quickly. And you tend to get prolonged bouts of respiratory failure, and that can be difficult with non-invasive ventilation as well. Now, I'm not going to spend a lot of time talking about the evidence for the use of high flow for acute hypoxemic respiratory failure, but there is one study that is important to mention, and it was the study by Jean-Paul Fratt, published in the New England Journal in 2015, done in intensive care units in France and Belgium. And they selected patients who had to have at least mild ARDS, PF ratio less than 300. They had to be tachypnic, not CO2 retainers, no chronic renal failure. They screened about 2,500 patients, enrolled about 300, distributed them equally between a non-rebreather, standard oxygen type of mask, nasal high flow, and non-invasive ventilation. On average, once enrolled, these patients had a respiratory rate of 33, a PF ratio 155, and about 3/4 of them had pneumonia, ARDS, and they were a pretty sick population. If they went on NRB, they were started at 10 liters a minute and went up to 15. Nasal high flow, and I want to point this out, they started at 50 liters a minute at 100% FiO2, and then they adjusted as necessary, but the actual FiO2 they ended up with was 82%. With non-invasive ventilation, they targeted a tidal volume of 7 to 10 mLs per kg, and the actual ended up being a pressure support of 8 and a PEEP of 5 with an FiO2 of 67%. And it is important to point out that the FiO2 actually was lower on non-invasive ventilation than with high flow, and I think that's because the pressure that you end up with is a bit higher. You get a higher PEEP, a higher level of pressure support, and that would lead to better oxygenation. It's also important to point out that NIV was used an average of only 8 hours a day, and the rest of the time these patients were on high flow. Here are the top line results. They had a trend toward a reduction in intubation when they looked at all patients combined, but it wasn't statistically significant. So someone who wanted to be nitpicking would say this would be a negative study because the major outcome variable was not statistically significant. However, when they went to, or they looked at the PF ratio less than 200 subgroup, there was a statistically significant reduction in intubations in the high flow group. And notably, They also showed a significant reduction in death in the ICU and also after 90 days. And it's not subtle, 50% down to 30% in high flow, a highly statistically significant difference. And this is the Kaplan-Meier curve showing the same thing, where we have this is the survival curve for high flow in red and for NIV in black. And there is a substantial difference between them starting relatively early on. And it was, again, fairly highly statistically significant. But there are problems with any study, and some of the concerns with this one was that the major outcome was not statistically significant, that it was nasal high flow was used most of the time, even when patients were on non-invasive ventilation. So how do you explain the mortality difference? They speculated that maybe it had something to do with the fact that their average tidal volume was 9.2 milliliters per kilogram, substantially higher than the 6 mLs per kilogram that the ARMA study, the ARDS study, showed was associated with better outcomes. But you could also argue that they targeted that. And if that was the difference, they set up NIV for failure in this study. Also, most of the patients who died had developed refractory shock, and it wasn't entirely clear why that would be. They speculated that it was because of the reduction in intubations in the high flow group, but that wasn't actually statistically significant, as pointed out. And it may be there might have been a little bit of a randomization area or error. And it is impossible to blind studies like this, so there is potential bias that needs to be replicated. But high flow has a number of advantages that go along with this, what Fratt showed an advantage, a survival advantage. As I pointed out, it is well tolerated, better than either standard O2 or non-invasive ventilation, and there are numerous studies that have shown that. And many of us, of course, have a lot of experience with it in other settings, and I think anybody who uses these modalities would not argue with that. I pointed out the advantage of secretion, hydration, and mobilization. And in the COVID epidemic, some of the patients who develop respiratory failure are found to have inspissated secretions, and we tend to run these patients dry. And so high flow can counter that. It is a good oxygenator. It has been shown to be better than standard O2, but not always than non-invasive ventilation. But because of its excellent tolerance, if you have something that people can tolerate 24/7, as is the case with high flow, but perhaps only a half or a quarter of that time with non-invasive ventilation, it does give it a big advantage. It does improve ventilatory efficiency. It can lower work of breathing, which might be important in getting people through their bouts of respiratory failure. Also, it's good for self-proning. We've been using this, and I've been hearing from a number of other centers that with high flow, you can have people self-prone. You just tell them to roll over and stay there for a while, and this has been associated, people are thinking, with better outcomes, although we don't have the data yet to prove that. There's a lot of interest in studying that, and our center is one of them. It may avoid intubation and conserve critical care ventilators that then can be used for people with very severe ARDS who really need them. And it's possible that better outcomes might accrue from avoiding intubation. And I've been seeing a lot of chatter on the internet about this, the idea that maybe early intubation is not such a great idea. And it also is good for palliation because it's well tolerated and it can make people more comfortable, even if they're not going to be intubated and supported with life support. But there are some caveats, and one is that it is not a pressure generator. It has some positive expiratory pressure, but it would be less attractive for people with severe COPD exacerbations or cardiogenic pulmonary edema. And there is always, with non-invasive techniques, a risk of delayed intubation, which we try very hard to avoid. We do not want to have emergency intubation situations, especially in the COVID epidemics, where that's a good way to spread aerosol. In the SARS epidemic, the highest risk aerosol generating procedure was intubation. And there's a lot of concern about the risk of aerosol generation with high flow, as Sahel mentioned in his introduction. So what about that? What do we know about aerosol dispersion with these various non-invasive approaches? And non-invasive ventilation, in a study by David Wee about 10 years ago, where he was studying dispersion using a human simulated model, and he would have the model replicate tidal breathing, and he would inject smoke into the air, and he had a laser light detector that would look at the plume of smoke depending on various conditions, and found that the plume extended via the exhalation valve about a meter beyond the patient's mask. Nebulizers also generate a fair amount of aerosol, mainly during exhalation, especially if patients are coughing. Simple masks like the Venturi mask, the NRB mask, disperse maybe half as far. And then high flow is way down here in the corner, which is just slightly more than just normal room aerosolization as a baseline. Now, it's fair to say that this is an artificial setup, and it's looking at the plume that arises from these different techniques. And this is a person who had a fairly firmly fit nasal interface with high flow. The authors said that if it was loose, it would disperse laterally more than that. But if you're careful, you can use high flow and not expect to generate a lot of plume. Now, none of these studies have looked at actual aerosol generation. They've used human models. It's not a clinical situation, and they haven't looked at dispersion of virus, which is also important. So there are limitations to this trial, but this is these are the actual pictures generated by Wee on a number of conditions. So on the left here, we have high flow, and we're looking at a human model from the side. You can probably see it better over here. This is the plastic face of the human model here. But on the left, this is the amount of plume when you're getting 10 liters a minute high flow, and this is at 60 liters high flow. And there's not a lot of increased dispersion at 60 liters compared to 10. There's clearly a little bit. And interestingly, they simulated more severe lung disease, stiffer lungs, as you might see in an ARDS patient, and the plume actually diminished in size. They compared it to CPAP, and this is on the right here, CPAP of 5 and CPAP of 10 under the same lung conditions. And the amount of plume using a nasal prong interface was not much different than we're getting with the high flow in this study. Now, a lot of people have recommended putting droplet masks over the nasal high flow device to reduce dispersion of aerosol. And this is a study that is in revision, as I understand it, with chest, that was done by the authors are some people who work for one of the manufacturers of high velocity nasal insufflation, which uses narrower bore prongs, and then the velocity of air entering the nose is greater, and the manufacturer thinks that this creates more eddy flow in the nasopharynx and maybe more effective at clearing out dead space than some of the other systems, although most of the work they've done has been in artificial models and in a clinical setting. I don't know that it works any better or worse for that matter. It seems to work comparably with the experience we've had. But one thing that is very striking here, this was a study that again looked at a human model, and this is looking laterally. But here's a patient who is getting 6 liters a minute from the high velocity system, but of course this is a lower flow, and you put this system on higher flow, and there is obviously a bigger plume, but over on the left they have put the surgical anti-dispersion masks on the patient, and there's virtually no plume at all, and you can see there's some accumulation of the red labeled gas here, a little less at the lower flow, but it's not escaping, and it looks to be pretty effective at reducing dispersion. They didn't look at the time factor here, whether this holds up over hours, how often the mask might have to be replaced, and so forth. But I think it's pretty impressive to suggest that the mask is effective at reducing dispersion. Now, that's one way of looking at things, but it's also important to understand whether our caregivers are actually getting infected. And so there have been a number of studies that have looked at this, and they were summarized in this meta-analysis by Tran that was published in PLOS One in 2012. So most of these studies were done on SARS patients, and there was one outbreak in Toronto where a number of caregivers who were present at an intubation were infected, and so intubation was rated as the #1 reason that healthcare providers were being infected. But tracheotomy is pretty high too. Bronchoscopy is high risk. Non-invasive ventilation was up there as well. Bagging before intubation, that should say, also up there. But look at high flow cannula. It was actually less than 1. The odds ratio was less than averaged. Now, this was based on only one study, and all of the studies were deemed of low quality. So I would caution anybody from over-interpreting this, but it certainly suggests that high flow is not of huge risk and confirms what we fear about intubation, especially a difficult intubation, that it is a high-risk procedure. So what about clinical applications of high flow? Where should we be using it? Well, I think it does very well with hypoxemic respiratory failure. Many of us are using it routinely in other settings for that. Our practice is to start high flow when 6 liters a minute via standard nasal prongs is no longer sufficient. But we're careful. You want to use it in people who are not having terribly high O2 requirements, patients who are relatively stable or improving. We do a 1 to 2 hour checkpoint, and we watch these patients like a hawk. And in COVID, this is particularly important because we do not want emergency intubations, which are a hazard to our healthcare practitioners. We also use it post-extubation when patients aren't quite ready to do it on their own on room air, but it's well tolerated. And there are a number of studies in the non-COVID setting showing that high flow either works as well as non-invasive ventilation in the setting and better than standard oxygen in avoiding reintubation. And then we also use it in the palliative situation because it's so well tolerated by patients and can effectively provide comfort as it oxygenates. Non-invasive ventilation, on the other hand, most of us are reluctant to use non-invasive ventilation, partly because it's not as well tolerated, so it requires staff to go in and out of rooms more often. And it also has not been shown to be highly dependable in people with hypoxemic respiratory failure. So we use it in people who are already on non-invasive ventilation or CPAP at home, and patients who have the usual indications like COPD exacerbations, cardiogenic pulmonary edema, also post-extubation, and in some situations do not intubate patients. Now, Many of you have been hearing about the helmet. There's been a lot of talk about it in the COVID epidemic. My friends in Germany, in Italy, where they've had a large pandemic and many people dying, have been using it as their #1 interface because they find it's pretty reliable. It's easier to control the leak, and it cuts down on aerosol if it's properly applied. And they find that the patients tolerate it pretty well. There is one notable study that I wanted to mention about the use of the helmet. It was done at University of Chicago, and many of you have heard about it or are familiar with it, but they used a helmet using a critical care ventilator, dual limb circuit, 8 of pressure support, 8 of PEEP, compared to a full face mask using a single limb bi-level type circuit with an expiratory pressure of 5 and an inspiratory pressure of 11. They had roughly 80 patients in the study. They were quite ill, PF ratios of 120 to 140 in the 2 groups. But the reduction in intubation rate was remarkably high, with 62% requirement for intubation in the full face mask group and 18% in the helmet group. Really striking difference. And then likewise, reduction in respiratory failure and also in mortality. And here is another Kaplan-Meier curve, helmet versus face mask, and really striking difference in survival curves. But there are concerns here, like with any study. And one is that huge reduction in intubation rate has not been seen in prior studies, and the Italians have been studying this device for 20 years. But even if it's half that good, I think it's still worth considering in these COVID patients, partly because it's well fit. It does minimize aerosol generation. There's an 8-hour run-in period on the full face mask before patients got randomized in the study, and that I don't know how that affected the results, because patients had to be able to tolerate a full face mask for 8 hours, then they get randomized, and then the intubation rate is so different after the first 8 hours. In my experience, a lot of people get into trouble within that first 8 hours. They use different ventilators, different settings. Was it the interface or was it that? It's a single center, small numbers, and you can't possibly blind a study like this. So this also needs some replication and comparison with high flow. Now, where does invasive fit in with this? Well, most patients are going to end up being invasively ventilated. The usual ARDS situation, it's 80 to 85%. I think it's probably the same in the COVID epidemic. So invasive mechanical ventilation is the default mode. And we use high flow and NIV for selected patients. And if they're rapidly deteriorating, they come in the emergency room and their oxygenation requirements are going up as before our very eyes. That patient, I would just go ahead and intubate without delay and not fiddle around with non-invasive techniques. Timing is very important here, and you want to avoid emergency intubations. But as Sahel was saying, the outcomes of invasive mechanical ventilation in the COVID epidemic have not been good. In China, the studies that they published, 60 to 97% mortality rates in people who have been intubated. In Seattle, it wasn't actually much better. There have been a couple reports there, relatively small studies, and many of them were still in the ICU on ventilators when the reports came out. But their outcomes are terrible. So the concern a lot of people are raising is, are we doing our patients a big favor by intubating early? Or, are we placing our own welfare as caregivers over the potential outcomes of patients? I have a fear that we are intubating people who don't need to be intubated and could be managed non-invasively, and we're contributing to their poorer outcomes because they end up on ventilators for long periods of time, and with all the complications that we are familiar with invasive mechanical ventilation. Now, the practical application of non-invasive ventilation in COVID patients ideally should be carried out in a negative pressure room with 12 air exchanges per hour at least. And I don't know about you, but at our centers, we don't have enough negative pressure rooms for everybody. And some of our high flow patients are not done in negative pressure rooms. If that's the case, we generally will have a HEPA filter in there. But a lot of the issue is that we need good personal protection equipment. And patients who are on these non-invasive devices should have what we call tier 2 protection, which includes N95 masks or powered air purifying respirators or PAPRs. In the SARS epidemic, later on in the epidemic, when in China they were using good protective equipment, there were a couple of studies totaling about 150 patients where none of the healthcare providers were infected. And in my own center, we have, we're not aware of any healthcare providers who have converted their COVID status based on exposures. Nothing that we can epidemiologically nail down. None of our respiratory therapists have become positive. We've had a few nurses become positive, but it looks like they got it in the community. So in our center anyway, the PPE seems to be doing a good job. You use a droplet mask over the nasal prongs, as we said, and you need to use adequate flow. I'm aware of one guideline where they said you can use high flow, but don't go over 10 to 15 liters a minute. Well, if you do that, you're losing all the benefit of high flow. You know, I generally say if you want to use high flow, use high flow. I recommend starting at least 40 liters a minute, maybe 50, because if you start at low pressure, low flows, our experience is that people generally leave them low and they manipulate the FiO2 to provide oxygen. But if you want to get the real benefit, avoid the air entrainment, get good flushing of the dead space, you need to use higher flow rates. And as the figure I showed you demonstrated, at least with the standard high flow that most hospitals use, you don't get that much more of a plume at 60 than you do at 10. And with non-invasive ventilation, we generally will use a dual limb circuit with a critical care ventilator so we can get a good viral bacterial filter. If you are going to use a single limb circuit, you can use a filter as well that can be attached to the exhalation valve. I wanted to just wind up with talking about predictors of high flow failure, because we haven't had as much experience as with non-invasive ventilation. But if you summarize the literature on this, persistent tachycardia, failure to improve oxygenation within the first hour or two, thoracoabdominal dysynchrony, especially with paradoxical breathing, need for vasopressors or organ failure score that is rising. These are all bad prognostic findings, and one would want to intubate sooner than later. And we're pretty compulsive about doing a 1 to 2 hour check after starting. And if people continue to deteriorate, their FiO2 is increasing on high flow up above the 60 to 80 range, depending on other things, then we would go ahead and intubate that patient. And some of you undoubtedly saw this Blue Journal article last year where they described the ROX index, respiratory rate oxygen index, which is the SF ratio, the SpO2 divided the FiO2 divided by respiratory rate. And the illustration is, let's say we have a patient with an FiO2 of 95%, FiO2 0.6, that yields a ratio of 158 divided by respiratory rate of 32, and you get 4.93. And the basic idea here is that the lower this ratio is, the worse people do. So if you need a high FiO2 to sustain, you know, a low SpO2, you're going to get a low number here and you divide that by a high respiratory rate, you're going to get an even lower index. And in this study, they found that at 12 hours, if the index was under 4.88, as it was in this patient, then that would be bad news, and you might want to consider intubating. The lower it is, the worse. Earlier on, they had to use lower indices because it was still possible that patients might improve over the next 6 or 12 hours. And they validated this using the FRAT data as well. So to summarize, high flow has a number of advantages for COVID patients and may avoid intubation, but it needs to be used selectively. NIV also selectively, especially for COPD and cardiogenic pulmonary edema. Aerosol mitigation appears to be effective, but exposure is always a risk, and we're never going to get the exposure levels down to zero. But with high flow and droplet mask, I think you do pretty well. It's critically important, though, to use meticulous PPE technique, and always keep in mind that you want to delay a needed intubation and avoid an emergency situation. And I will stop there. Thank you for your attention.
Nick, that was an excellent presentation. Thank you so much. I think you have very nicely synthesized the available data and made certain recommendations that clinicians at the present time may be able to utilize and appropriately manage their patients. So in summary, what I as a clinician learned from your presentation is that there may be a specific role for high flow oxygen in the hypoxemic respiratory failure found in the COVID epidemic, that you could use it to avoid intubation. You can certainly use it post extubation, especially in the patients who are demonstrating respiratory distress with tachypnea, or in whom the saturation is dropping. I think you nicely brought out the fact that the risk of aerosol dispersion seems to be low based upon the scarce data that is present. However, if we were to have the luxury of having negative pressure rooms, then the risk could be reduced even further. But I think that all of us should emphasize the importance of using appropriate PPEs and N95 masks or N100 masks. I think that the data you presented about the helmet is really intriguing. There was a very significant reduction in the rate of intubation with helmet masks, and time will tell, and other studies from other centers would have to be done to bear that kind of very significant data. I think we don't have very much time, but I just want to thank you for having done a terrific job. And I think for so many physicians who are grappling with this epidemic, your presentation is going to be very, very useful. So thank you so much indeed, and appreciate everything that you've done and all the time that you've put in to give this information to us.
Well, thank you, Sahel. You've done a masterful job of summarizing a lot of the points I was trying to make. And thank you again for moderating this. I'm really honored to have you aboard.
Thank you so much indeed. God bless. Take care of yourself.